I really used to laugh at those folks. You know the type I mean, to use gadgets like this, Withings and Fitbits, measuring everything that went in and out of their bodies. In 2011, this field was called quantified self. It really took off. And I used to really laugh at these folks. Until 2012, when I stepped on a scale and I weighed 247 pounds. And I thought to myself, when I hit 250, they can measure me in tons. That's 1/8 of a ton. This is literally what I look like during my 2012 TED Med talk. Some people are embarrassed to see their videos. I was really embarrassed to see this video. I thought to myself, what happened to me? I'm driving everywhere in Silicon Valley. I used to walk a lot. And I bought everything Fitbit makes. I started tracking my steps, like many of you do now. But actually more interesting, I started to weigh myself every day. And I record everything I eat. I've recorded every meal, every day for the past 5 years. And I lost 50 pounds in 2.5 years. Now, this is a data-driven weight loss. And me, as a data scientist, this was an incredible experience. I learned a lot. I learned that it doesn't really matter about the quality of the food entries you make. I know the good days, I know the bad days. But in a precision way, I now know which are the foods that add excess calories to my waistline. It doesn't matter if the data is inaccurate, the learning is precise. Now, I'm not giving a product testimonial for Fitbit. Not everyone gets the same results. I'm an early adopter for a lot of these gadgets. I love the social aspects. All of my friends on Fitbit, on Facebook, know with my Fitbit, I lost 50 pounds. But here's the interesting point. I made the most major health intervention of my life. When I went to go see my primary care doctor at a major medical system near here, and they spent $1 billion installing an electronic health record system, my primary care doctor was the last one to know I lost 50 pounds because their $1 billion system doesn't talk to my $40 gadget. And that has to change. We have to make that change. And like that, medicine is going to change from this bygone era of hands-on practice into a new era of data-driven medicine. Now, data and computation have changed many fields over the past few decades. It was only a matter of time before this happened to medicine. And data by itself doesn't do anything. I, as a patient, I want to share my data now with those that care about me and those that care for me. But this is a partnership now. The physician of the present or the physician of the future needs to accept that data and send back advice and recommendations. That doesn't happen today. So let's not lament the fact that data is driving medicine in the future. Let's celebrate it, and let's use it. And let's get more patients and healthcare providers using the data that's out there. We have so much data in medicine today, unbelievable amounts of data. We have data on individuals, data on patients, data on physicians. We have data on the quantity, quality, and composition of the care we're delivering, or the lack of quality in the care that we're delivering. We have data on performance of physicians and nurses. We have data on the price of medical devices and pharmaceuticals. We're entering an era of big data in biomedicine. Now, some of the biggest data actually comes from the health systems and the physicians and the data they generate with you. For example, molecular data. We're getting more and more measurements of molecules, whether proteins or DNA, from you or your tissues or your tumors someday. On the left is the Whitehead Institute, a picture of the Whitehead Institute, one of the centers that generated a good chunk of the Genome Project that ended in 2003 after 13 years and $3 billion of effort. And on the right is my hand holding a USB stick sequencer. One of these actually works on the space station now. It's a no-brainer. We're going to be getting more molecular data from patients in the future. There's imaging data, whether it's X-rays of chests or lungs or bones or CT scans or MRIs. These are enormous files, ranging from 3 megabytes to 3 gigabytes, depending on the type of study that your physician might order. And then there's claims data. What's a claim? A claim is how we in medicine send a bill to get paid. Here's an example of a handwritten claim you can find on the internet. They're electronic now, of course. But at the top, you see some information about a patient, their address, their age. And then you see codes at the bottom, codes on what do we do with these patients, and what disorders or conditions we think the patient has. These are how we in medicine get paid when we see a patient. But claims can go only so far to represent a patient. Even though these are electronic, and we've had them for decades, you can already see how limiting they can be. The ultimate data to have are your medical records. Let me give you an analogy of the difference between claims and medical records. Let's say I told you that I really love going to this restaurant called Bricks up in Napa Valley. Maybe some of you have been there. And you're curious, why do I love this restaurant so much? Does it really help you to look at the bill? You can see I spent a decent amount of money there. Maybe I had a nice party there. But wouldn't you rather see what we ordered at the restaurant? You can see we ordered the crab cakes. You can see we ordered a Baldacci Pinot Noir. Which of these would you rather have to actually understand what are we doing? What was our experience at the restaurant? And that's the difference between medical claims and medical records. Medical records are the ultimate record of what actually is happening to a patient. What exactly is a medical record? We're asked to think about these all the time when we sign forms. What is in a medical record? Well, medical records go back to 1907. They were invented at the Mayo Clinic, so it's been 110 years since we've had paper-based medical records. And when we think of medical records, we think of shelves like these. You remember seeing these maybe when you were growing up? These are paper-based records in an outpatient clinic, nicely organized with stickers and handwritten notes inside. But these are for outpatients. The minute you actually come into a hospital, your medical record grows. They become enormous. And they're stored in binders like these. And these binders were strictly defined. They would start with the medication orders, then the admit note and the progress notes, followed by the flow sheets and the nursing notes, and then the lab test results and radiology and pathology. And then somewhere in the back were the social work notes. It's almost like we had a pecking order in medicine physically implemented through the medical record. You can only put your notes in the right place. Now, of course, today, these are all electronic, but back then, these were enormous records. In the newborn intensive care units, we used to celebrate when our tiny baby patients probably weighed more than their medical records. But now, of course, they're electronic and they only weigh electrons. They weigh electrons, but they cost billions of dollars. Here are 3 examples. Sutter spent $1 billion on their electronic health record system. Partners over in Boston spent $1.2 billion. And Kaiser spent $4 billion on their electronic health records. Just a tad bit more than the 99 cents you're questioning whether to purchase in the App Store for an app. Now, it's kind of funny if you look at these headlines. The $1 billion Sutter spent is written up as a boondoggle, but the $4 billion Kaiser spent is written up as winning a bet. And they bought the same software. It pays to have the right friends as reporters. And these electronic record systems are costing us billions. Now, instead of the sections of the record, we now have tables, up to 18,000 tables making up the databases that feed the electronic health record systems. We have tables that record every encounter, inpatient and outpatient, every drug ordered and dispensed, every vital sign, every lab test result, and of course the notes. All of those millions and millions of text notes, every admission note, every progress note, every discharge note, every phone call gets documented in all of these notes. Enormous amounts of data. Yet, despite all of this data, we're still sometimes missing the most obviously relevant pieces of data. Let me give you an example. If a big city hospital sends you home after having major surgery to get care by your regular primary care doctor, the big city hospital might never actually know what happened to you after that surgery. That's called your outcome, your outcomes. The only raw form of outcomes the big city hospital might have is called your discharge disposition. Do you know what discharge disposition is? Did you die or did you leave? And if you left, did you go home? Did you go to a hospice? Or did you go to another hospital? Discharge disposition is like that other Oak Ridge Boys song. You don't have to go home, but you can't stay here. So imagine the very next thing that happens to you, whether you did better or worse, is stuck in someone else's major computer system. Let's think about how ridiculous that is for a moment. Let's imagine you're learning how to play a game called chess, or teach a computer how to play chess. Wouldn't you think the computer would want to know which moves it made that led to a winning game or a losing game? Now imagine trying to learn how to play chess, and you only get the first half of the game. Or imagine trying to learn to play chess, and you only get the last half of the game. Right? Isn't it obvious how limiting that is? If these systems can't talk to each other, we got to do better than this. We got to create new methods and, more importantly, new business models to get health systems to start to share this data with each other. And we're doing this in the University of California. But more importantly, we need to figure out how to get this data from you, because you know if you're doing better. Beyond just surveys of whether you liked our care or like the parking structure at our facilities. Are you actually doing better? We need to do better than this. And we can do better than this. We got to actually build these systems and actually start to tap into ways that you can electronically communicate with us to give us the data we need. Now, we have all this data, and we spent billions to acquire it, but how are we going to get this to the scientists and analysts and software engineers who know what to do with this data in a safe, respectful way? It's your medical record data. We have to de-identify that data. And to me, it's really important for me to teach you what does it mean to de-identify medical record data. De-identification is not something we can make up. It's coded in federal law. Up here is an example of the federal law. We have to remove 18 different types of identifiers from that medical record that make us know it belongs to you. For example, at the top, it's obvious we got to remove your name from the record. We got to remove the dates that we saw you, and so much more, and we tell you we're doing these things. And then after we've de-identified these records and certified they're de-identified, then we can get this to the software engineers and the analysts and the scientists to figure out what's working in medicine and what might be excessive in medicine. And when we combine that clinical data and molecular data and wearable data and behavioral data and your preferences, when we combine all that, maybe then we can customize the healthcare we deliver to you. And that is what we call precision medicine. The customization of healthcare we can deliver to you based on all of that data, and not just from you, but from the entire population with the outcomes to learn what is working and not working in medicine and apply it to you. Now, to get there, we're going to need to build an enormous database. We're going to need a lot of people sharing their data in a safe, de-identified way, and the molecular data and the clinical data and the imaging data, and then give that to scientists. And how are we going to get there? Well, one way forward is through the Precision Medicine Initiative, and now called the All of Us Research Cohort. This is the goal that President Obama set out years ago, to recruit 1 million or more volunteers, maybe some of you, to contribute to your medical record data and your molecular data and blood tests, and de-identify that so we can learn what keeps healthy people healthy and what can we do to customize the care for those that are ill. We have a long way to go to build this, but you're going to start to see health systems and physicians asking you to start to participate in research studies like this. And I do hope you start to say yes. What am I trying to do for precision medicine in the University of California? I'm trying to build maps. Maps of death and disease. Now compare that to Google Maps, which takes you to pleasant destinations. I'm trying to figure out how Californians get diseases and die in our state, right? Here's an example of a map made by Hannah and Jay. Hannah was a researcher in my lab. She runs her own research group now in Korea, and Jay helped us with the visualizations. Here's an example of a map with real California data. On the top left circle, that means that we see patients showing up with alcoholism. And then if you go to the bottom right, a year later, we see those same patients showing up with liver disease or liver cirrhosis. And then if you zip back to the left there, they're showing up with liver abscesses. And you can do the zigzag or you can come straight down. The squares mean the patients died of those two diseases. So it's really rare to die of alcoholism. You typically die of those other two disorders. The maps can get very complicated. Here on the left, patients show up with acute myocardial infarction. That's a heart attack. You can die right away of that. But if you take the northern route, you end up next in a year with heart failure. That means the heart muscle isn't strong enough to pump the blood it needs, and you can die of that. Or that leads to lung disease, the orange circle, and the fluid starts to back up because the heart can't pump that blood fast enough. And the big blue circle on the right is sepsis, septicemia. That's a blood infection. Now, I'm a pediatrician. I never really saw many patients showing up with a heart attack, but I always thought that if you had a heart attack, it's the heart that does you in the end. But it's actually an infection that does you in at the end after 3 years. And if you don't take the northern route, you can take the southern route, and you kill your kidneys first and then end up with sepsis that way. And what I'm trying to do is to build these maps. Now, I love Google Maps. I use Google Maps all the time. But there's still one thing Google Maps can't do. Google Maps can't show you where all the cars are on the map. I know it shows you the traffic, but it doesn't show you each and every little car on the map. How could it ever do that, right? Well, for me, my vision for the University of California isn't just to build the maps and show the maps. I actually want to see what all of our 15 million patients are doing on the map. Where are they, and where are they going next? And this is a prototype with real California data. You can see as patients are getting older, we're making the colors brighter. The age is going up at the top right. A lot of them are starting to get diseases and die. A whole bunch of them are going to hit that sepsis purple circle in a moment, and they're going to die. There they go. And we can start to use this map, right? We can start to predict what's going to happen next. What's going to happen in the next 90 days? What's going to happen in the next year? And what are we going to do about it? And that, to me, is going to be the new definition for precision medicine. How can we actually use all of that molecular, clinical, behavior, preference data to accurately and accountably deliver precision care to our 15 million patients in University of California? And that's what we're trying to build. This is the future. So we're surrounded by data in medicine. But data doesn't do anything by itself. It's stuck. It's frozen in these ponds and puddles. They're your puddles, too. Go splashing in those puddles. Learn what's in your medical record data. And start to share your medical record data with scientists and researchers in these large research cohorts. We need everyone's help to build this new future of precision medicine. Thank you.